Good morning. I'd like to sign out my pager, please. 80330. It's Eisenberger. It's going to go to my office, which is 305-0527. Yep. Thanks so much. Bye-bye. Good morning. Buenos dias. So, again, nothing to disclose. Right, Tom? Again, just to state the obvious, it may not be obvious to you, but anemia means low red blood cells. And what I'm going to be talking about today is hemolytic anemia. Hemolytic means hemo meaning blood, lysis meaning breaking. This is when red blood cells are destroyed, earlier than they're supposed to. They don't live out their 120 days. And these are uncommon, but we see a lot of this. This is how I pay for summer camp for my kids. And some of these things people are born with, and some of these things people pick up later in life. The most important kind of first step in understanding why people have hemolytic anemia is doing something called a Coombs test. A Coombs test is basically a test when you're looking for an antibody against red blood cells. You have Coombs positive hemolysis, which is red blood cells being destroyed by an antibody in the blood, or Coombs negative hemolysis. And I'm going to go into this in detail. There are certain basic blood tests that you do on everybody with whom you're suspecting hemolysis or you're monitoring hemolysis. Indirect Coombs test, something called haptoglobin, lactate dehydrogenase. And this smear can sometimes give you very crucial information as to why a patient might be hemolyzing. So these are the blood tests that we look at when we're trying to evaluate whether or not somebody has hemolysis here. When you're looking at my slides, and this will also be true in the malignant heme course in the fall, I don't put the definitions up here because I want you to write down the definitions or look them up, because that's active learning as opposed to me just putting everything up there for you to look at, and then it goes in the left ear and out the right ear. So that's why I don't necessarily define these things. Red blood cells, in addition to being filled with hemoglobin, are filled with lactate dehydrogenase, which they use to get energy. And so when red blood cells are destroyed early, that goes up. There's a protein that circulates in the blood called haptoglobin that binds free hemoglobin when it's released from red blood cells, and the combination of hemoglobin and haptoglobin bound together gets cleared by the liver. And so a low haptoglobin tells you that there's hemolysis going on. Indirect bilirubin. Red blood cells are filled with hemoglobin, and that eventually gets broken down into bilirubin. You have total bilirubin, which is conjugated and unconjugated. And when you have hemolysis, you get an increase in indirect bilirubin. The liver doesn't have enough of a chance to conjugate it yet. And so you'll see that as well. When you have free hemoglobin in blood, some of it gets into the urine, and it can be resorbed, I believe, in the proximal tubule by tubular cells, and it gets converted into hemosiderin. And this is kind of a nerdy test that a few of us in the hospital know exists, but if you're looking for very subtle hemolysis, you can look for hemosiderin, which again is hemoglobin which has entered the urine, gets resorbed into tubular cells, and gets converted into hemosiderin, a modified protein. You guys have not had nephrology yet? All right, well, sorry. Also, in general, when you have hemolysis, accelerated red blood cell production, unless there's something else suppressing the body, you don't have enough vitamins like iron or B12, your body will naturally compensate for the red blood cell destruction by making more red blood cells. And so you'll see an increase in reticulocytes. So generally the reticulocyte percentage is 0.5 to 1.5%, 0.5 to 2%. So somebody with brisk hemolysis, they'll have a retic percentage of 5, 10, 15%. And that's a clue, that's a big clue for hemolysis. There's two ways of looking at hemolysis. I talked about Coombs positive and Coombs negative before. There's also what we call intravascular and extravascular hemolysis. Extravascular is hemolysis that takes place in the spleen. Until I was a fellow, this kind of blew my mind, because like, how could hemolysis take place outside of the vasculature? Because that's the only place where red blood cells really exist. But this just means that the red blood cells are being engulfed by splenic macrophages, as opposed to intravascular hemolysis, which is hemolysis which is mediated by complement. And sometimes hemolysis is just one, sometimes hemolysis is just another, but it's often a Venn diagram where you see both coexisting and it's majority of one versus another. And as I go through the different forms of anemia, you can ask, is this intravascular or extravascular? So, as I said before, the major way of looking at hemolysis is whether it's antibody-mediated or not. Coombs is a dude who, in England, I think during World War II, who came up with this test. And so it's named after him. So this is a basic way to kind of break this down. And then, to break this down again, this antibody can either be a warm antibody that reacts at 37 degrees, which is your temperature, or a cold antibody, which reacts at lower temperatures. And I'll explain that in more detail. Coombs negative hemolysis can either be something that you're born with or something that you're unlucky enough to get. Now we can take this a step further. And Coombs negative hemolysis, if it's inherited, there can be a problem with an enzyme in the red blood cell that renders it more easily destroyed. There can be a problem with hemoglobin, especially sickle cell disease, which we'll talk about in the next lecture, which leads red blood cells to get destroyed too easily. There can be a problem with the red blood cell structure that allows it to hemolyze. We talked about spherocytosis and elliptocytosis yesterday. And sometimes red blood cells are not destroyed by antibodies because there's nothing wrong with the red blood cell from birth, but it's getting destroyed because something's going on in the body that's just, in the vasculature that's chewing it up. Or something can happen to the red blood cell later in life that makes it more easily destroyed. And if this looks confusing, we'll take it a step further and completely blow your minds. But again, I didn't start off with this slide. I didn't start off with this list, with a simple list. The way to think about hemolysis is to go back to this, and then take it a step forward, and then take it to this step, and then take it to this step. And that will help you. This is how I organize my thinking as a blood specialist, and this is how you should try to remember things in this course, rather than coming up with a simple list of things that cause hemolysis. This will make it more intelligible to you. I'm not going to go over all of these things today. Where is my pen? Let's do green today. This will be discussed tomorrow. This we won't really talk about very much. This will get discussed later in the week. This we kind of talked about yesterday, and we'll talk about briefly today. Sickle cell disease and thalassemia is on the next lecture. But I'm going to talk about the other things that I haven't really circled. So let's talk about antibody-mediated hemolysis. This is the Coombs test right here. If you just look on the upper left-hand corner, this is the patient. The patient has erythrocytes which have red blood cells on the surface. You take blood from the patient, you put it in this test tube right here, and this right here, these are antibodies that recognize the constant region of human antibodies. These are from a rabbit or a goat or a bat or whatever. And basically, if you have antibodies attached to human red blood cells, these blue antibodies will attach to them, and you'll get agglutination and hemolysis. And this is called a direct Coombs test because it's a one-step reaction. You get a result directly. This looks for opsonized red blood cells, red blood cells which are coated in antibody. The indirect Coombs test gets its name because it's a two-step reaction. You don't get the result directly. This is different than the first step here. Here, you're not looking for antibody-coated erythrocytes. Here, you're looking at the patient's antibodies. You're getting the patient's serum, the liquid portion of blood that has the clotting factors removed from it. And you're looking for the patient's antibodies. And then you you mix these antibodies with reagent red blood cells. You know what these red blood cells have on the surface, and you see whether or not these antibodies and these red blood cells will react with each other, whether or not the antibodies will attach. If they attach, you've got your first step done, and then the second step is the same thing as the direct Coombs test. You're adding antibody to human antibody to the constant region here, and you're looking to see whether or not you get hemolysis. This is only positive in patients who have antibody-coated red blood cells. This could be positive in someone who doesn't have hemolysis. For example, if you're a pregnant woman and your fetus is a different blood type than you, you'll get exposed to that fetus's blood when you're delivering it, and you'll have an antibody to it perhaps forever, but you won't have hemolysis. So you have warm and cold mediated hemolytic anemia. Warm is IgG, cold is IgM. This is an overgeneralization, but this is what we start with. IgMs usually fixed complement, which I think you've done immunology? Okay, so you know what complement is. So often we will not even detect IgM on the surface of red blood cells, we'll just detect complement. And sometimes you get complement with IgGs, with warm antibodies. The hemolysis in warm antibody is almost exclusively extravascular. It means it only happens in the spleen, and it happens in the spleen and also within the vasculature in cold antibody hemolytic anemia. So this is what happens in extravascular hemolysis. Here is your erythrocyte. These little blue things are proteins that it has on its surface. And there are hundreds of proteins on the surface of erythrocytes. And an antibody comes along and recognizes them. And the erythrocyte's just going around doing its business. But then, in the spleen, you have a splenic macrophage. And this plus sign right here is basically a receptor, which is called the Fc gamma receptor. It's a receptor that looks for basically looks for the constant region of antibodies. And so this is how macrophages looks for opsonized material, things that it needs to eat up and destroy because it's attached to an antibody. And it recognizes the antibody attached to erythrocytes, and it ends up taking a bite out of the erythrocyte here, and it loses its biconcave disc and becomes a microspherocyte here. And remember, biconcave discs are floppy and get through the vasculature very easily. Spheres are not floppy, and so these microspherocytes get stuck in the splenic circulation and end up getting destroyed prematurely. That's extravascular hemolysis. And these are microspherocytes right here. These normal cells have central pallor. These do not. And that's how you can tell the difference. And they're smaller because the macrophage has taken a bite out of them. If you remember, IgM is a pentamer. And so the smear for someone with cold antibody hemolytic anemia, this looks like globs of red blood cells stuck to each other. Importantly, if this is prepared at a warm temperature, you won't see this because it only reacts with red blood cells at temperatures, or generally in temperatures less than 37 degrees. So you have to prepare the smear under cooler temperatures to see this reaction. Warm antibody hemolytic anemia is 99% of what we see, maybe more than that. Cold antibody is rare. We had a case of it recently. We knew we had it. It took the blood bank 2 or 3 weeks to be able to figure it out because it's rare and difficult to diagnose. So the majority of what you're going to see in your careers is going to be warm antibody. Warm antibody is often idiopathic, which means we can't figure out where it came from. There's no disease association with it. But you also often will see warm antibody hemolysis in lupus. You'll see it in hepatitis C. You'll see it in different forms of lymphoma. Cold antibody hemolytic anemia is rarely idiopathic. The kind of classic association is mycoplasma pneumonia. I think you've had eye infectious disease, and so you've heard of this before. Mononucleosis can cause this. Lymphomas can cause this rarely. There's a bit of information here just in terms of the treatment of antibody-mediated hemolysis. The take-home point is you always treat the underlying disorder. If the patient has lupus, you treat lupus. If the patient has lymphoma, you treat the lymphoma. For warm antibody, you always give steroids first. You don't really do it in cold antibody. Cold antibody, the main treatment when we need to is something called Rituxan, which we'll talk about a lot this week. It's a monoclonal antibody to B cells. B cells are the cells in the body that produce antibodies, and so if you kill off the antibody-producing cells in the body, you'll get rid of the IgM or the IgG, which is destroying the red blood cells. Sometimes this is also given for warm antibody hemolytic anemia. Sometimes you actually have to physically remove the antibody from the body to get rid of hemolysis, and this is called plasma exchange. You take out the patient's plasma, that's the liquid portion of blood, and in that is the antibody which is attacking red blood cells, and you give them normal plasma back. IgG has a half-life of 3 weeks, so this is not very effective for IgG-mediated hemolysis, but IgM has a half-life of 5 days, and so if you have a patient with very brisk hemolysis and you cannot get it under control, you can do plasma exchange, and in a few days you get rid of most of the antibody that's attacking the red blood cells. Interestingly, when you transfuse patients with cold antibody hemolytic anemia, you need to give them warmed blood. The blood from the blood bank is in the refrigerator, and if you give them cold blood, it'll get hemolyzed as soon as you give it to them. Questions before I go on? Okay. So Coombs negative hemolysis. So there's a few different enzymes within red blood cells that the red blood cell needs for its 120-day lifespan. The main one that I'm going to talk about is something called G6PD deficiency, because it's the most common of these, and the other ones are pretty rare. These red blood cells, as they're going through circulation round and round for 4 months, are constantly exposed to oxidative stress right here. Here you see a hydroxyl group right here, and this can damage red blood cells. This can damage the protein inside red blood cells. So red blood cells need to protect themselves from this. And they do this, and the body does this in general, with a protein called glutathione, which is produced in the liver. I think you guys you've done GI? Okay. Yes? No? Okay. This is a protein called glutathione, which is used to reduce the hydroxyl group here. And so you get rid of this oxidative stress, and you guys remember NADP. I don't, but you need NADP to generate glutathione to get rid of oxidative stress. And in order to regenerate NADP to NADPH, you need an enzyme called glucose-6-phosphate dehydrogenase. This is part of glycolysis right here. And so if you don't have enough of this enzyme, if you're born with insufficient amounts of it, you can't deal with oxidative stress, and you'll get oxidative damage, and this does bad things to red blood cells. You get what we call bite cells. This looks like this red blood cell has had a bite taken out of it. And blister cells. This has another bite taken out of it. Here's a cell with a blister on it. And again, you can just Google this stuff and find billions of pictures of this stuff. The oxidative stress causes this to happen in the red blood cells. And one of the things that happens is you will get precipitation of nucleic acids, the residual nucleic acids in the red blood cells. It's nucleic acids, right? Or is it proteins that get denatured by... It's hemoglobin that gets denatured. And you'll get and if you stain this with a special stain, you'll get these bodies here, which are called Heinz bodies. Just remember this like this, put ketchup on everything like my kids. In practice, we don't do this very much anymore. But again, these are clumped, denatured proteins that have been exposed to oxidative stress. This is X-linked, which is crucially important. So the vast majority of people who get this are men, but you can see women who get this because of extreme lionization of the X chromosome, the same way we occasionally will get women who have hemophilia. This seems to be protective against malaria in some way, and so we see this in areas where malaria is endemic, like Africa and the Mediterranean. If you ever see fava beans on any standardized exam, it either has to do with G6PD deficiency or flatus production. And so it's usually G6PD deficiency. Fava beans create this massive oxidative stress, and so you can have patients who eat fava beans for the first time and come in with severe hemolysis. Infections can also trigger oxidative stress. It can trigger hemolysis. Diabetic ketoacidosis can do it. Again, it's an acidic, oxidative environment. Anti-malarial medications can do it. There are different forms of G6PD deficiency prevalent in different parts of the world, and people can be susceptible to different medications. Fava beans is kind of like the textbook answer. DKA infections are also very important. Remember, when someone hemolyzes with G6PD deficiency, the red blood cells, which are most deficient in G6PD, are destroyed. So if you suspect that somebody has G6PD deficiency, don't test them when they roll in the door with terrible hemolysis, because you're not going to find it. Those red blood cells have been destroyed. So you need to wait a month or two to be able to test red blood cells to see whether or not they have deficient levels of G6PD. Because what you're mostly going to find are the youngest red blood cells around, which have the highest levels of G6PD. And the treatment is just avoid fava beans, avoid medications which trigger this, avoid DKA, avoid infection. We talked about this yesterday, red blood cell structural disorders. These are mutations in cytoskeletal proteins which don't allow the red blood cell to maintain its normal biconcave disc shape, and therefore the red blood cells get trapped in the splenic circulation and get engulfed by splenic macrophages. And again, you have hereditary spherocytosis and hereditary elliptocytosis. And I showed you the proteins yesterday, ankyrin, spectrin. These are rare. We almost never see these diseases as adults. This is basically a pediatric disease. There's one treatment for this, essentially, when the hemolysis is severe, and you take out the spleen. Because these red blood cells will live, have a much longer lifespan if they don't get gunked up in the cords of Billroth in the spleen. And so once the spleen's gone, the hemolysis largely goes away. But many parents do not like to take away their children's spleens. So Coombs positive we've done. Coombs negative, we've covered inherited disorders. Now I'm going to talk about acquired disorders that can cause Coombs negative hemolysis. DIC will be discussed later this week. Just briefly, there are things that there are things that we put into patients that can cause hemolysis. We put them into the vasculature. So you can put in a heart valve, and if a heart valve doesn't function properly, it will start to chew up red blood cells. You can put in large catheters, like ECMO catheters, and if they get clotted or they don't function properly, red blood cells can get sheared and destroyed in there. TTP, thrombotic thrombocytopenic purpura. It's a rare disease, but we see it several times a year here. It's a fascinating disease. Make believe that this is the microvasculature here, and there's an injury. The first thing that happens when you have this vascular injury here is, here you have subendothelial collagen, and von Willebrand factor, which we'll talk about tomorrow, which is this big procoagulant protein, comes and sticks to the subendothelial collagen, and then a platelet comes and sticks to this. And this is how you get hemostasis. This is how you stop bleeding. Von Willebrand factor, again, to be discussed more tomorrow, is made by endothelial cells and is made as ultra-large von Willebrand multimers. It's this huge multimeric protein that's secreted in a very large shape, and it gets broken down into smaller pieces while in circulation. This is done by an enzyme called Pac-Man. Some of you may have heard of this. There's an enzyme called ADAMS13. I am not the nerd that named this protein. I won't tell you what it stands for. It's a long, nerdy name. But basically, this protein breaks up these ultra-large von Willebrand multimers into smaller pieces. It comes along and spits out smaller pieces. The ultra-large multimers are very, very sticky and can basically gum up the works. They can plug up the vasculature. And so you need a little bit of that, but more often you need these smaller ones for effective hemostasis to prevent bleeding, but not to the extent that you get thrombosis, that you get clotting. So in TTP, what happens, based on all this basic science, here you have these ultra-large von Willebrand multimers that are waiting to be broken into smaller multimers by ADAMS13. And then trouble happens, and there is an antibody that comes and binds to this, and you just have the kind of dying screams of it when it gets destroyed, the protein, and you're left with these ultra-large von Willebrand multimers. And this is what happens. These are very, very sticky. They stick to the side of the microvasculature. And normally, again, remember, you've got these biconcave discs that need to flop over to pass through the capillaries. And it can't do that because there's these big, stupid proteins in the way. And the blood is pushing them through the gauntlet. And instead of having these nice biconcave discs, you get what we call schistocytes. They're also called helmet cells because they kind of look like Viking helmets. We could put some horns on them. They kind of look like the ghost from Pac-Man, actually. So anyhow, when you see schistocytes on the smear, this should make you think about TTP. It's not the only disease where this happens, but again, the ultra-large von Willebrand multimers get stuck to the endothelium, and the red blood cells try to get through, and basically because of mechanical stress, they get broken up into schistocytes. This is the kidney right here. You'll learn about this sometime soon. The kidney has the unfortunate job of making urine, which makes it an inferior organ to blood. And it has a microvasculature too. And so when this same process goes on here in the tubules in the kidneys, you get what we call hyaline membrane formation here. Basically, your kidneys can fail because these ultra-large von Willebrand multimers get stuck in here. And you know, you lose your kidney blood flow. So this is called microangiopathic hemolysis. It's hemolysis that's going on. Microangiopathic means small blood vessel. It's also called thrombotic microangiopathy. Thrombotic means clot. And you're getting clot in the small blood vessels, which is leading to hemolysis. It's also called MAHA or TMA, are kind of the abbreviations. This is the most important mnemonic device in this course. And I remember this from when I was a second-year medical student. This is the pentad, which is used to diagnose TTP clinically. And you shouldn't say it out loud in front of the nurse's station. I didn't make it up. I wish I could take credit for it. These are the things that you can see. My boss is so embarrassed of me right now. You don't need all 5 of these to diagnose TTP, but any of the 5 of these can occur in patients with TTP. This is kind of the core 2 things that you need to see in TTP. You need to see thrombocytopenia because platelets are getting consumed in these clots in the microvasculature because of the ultra-large multimers. And you need to see anemia, but it's not any kind of anemia. You need to see schistocytes. You need to see microangiopathic hemolytic anemia. At minimum, you need to see these 2 things. Sometimes these patients are febrile. Sometimes these patients are confused and act like, or even are having frank strokes. Sometimes these patients have kidney failure. But you don't have to have the F and the R and the N. At minimum, you need to see these 2. The intensive care unit, just over next door in Milstein, is filled with people who have all 5 of these. But importantly, it has to be microangiopathic hemolytic anemia. You have to see evidence of hemolysis in the blood work. You have to see schistocytes, the helmet cells, on the blood smear. One of the most common reasons why people constantly come to the hematology-oncology office to our fellows with blood smears, looking because they want to see if there are schistocytes on the smear, because this is such a feared diagnosis. This is how we diagnose TTP. We do a complete blood count, and we do a reticulocyte count. And the reticulocyte count should be elevated, because it's hemolysis. So we should see high percentages. We should see high indirect bilirubin, high LDH, haptoglobin. Again, haptoglobin decreases when you have intravascular hemolysis because the protein is binding to free hemoglobin getting cleared by the liver. This should be undetectable. Skip the urinalysis because you haven't learned about urine yet. You will see markers of end organ damage. Creatinine, an elevated creatinine, you'll learn about in a few weeks, creatinine is a blood test we use to monitor kidney function. When creatinine goes up, it shows you that there's kidney damage. And so that's one marker of end organ damage in TTP. There's no blood test to look for brain damage, but the heart is another important organ which has a microvasculature. You've learned about the heart, right? So if you see elevated troponins, if you see an elevated B-type natriuretic peptide, BNP, which is a marker of heart failure, these can be clues also that a patient has TTP. You will learn tomorrow about the clotting tests called the PT and the APTT. These are ways of looking for deficiency of clotting proteins in the blood, and these tests are normal in TTP, but again, I'm kind of triangulating this with future lectures. So just know that the PT and the PTT are normal in TTP. It's very common, it's not unusual for patients with HIV to develop TTP. So especially if a young person comes to the hospital with a new case of TTP, one of the first things we do is we do an HIV test. And the other thing that we do is we check the level of ADAMS13, this enzyme which is deficient. And it takes about a week for this test to come back, but there's a blood test that we can do. It's a send out to an outside laboratory where we look for the level of activity of this enzyme, and if it's very low, it will help us look for that antibody which is attacking the enzyme. How do we treat this? The first thing we do is give steroids, because steroids help get rid of bad antibodies. We do plasma exchange. Plasma exchange is when you take the liquid part of patient's blood, you remove it from the body, and this is done with a machine, not with a medical student, and the machine removes the patient's plasma, and then you give donor plasma back. And when you remove the patient's plasma, you remove that antibody to ADAMS13, to that enzyme which breaks up von Willebrands into smaller pieces, and that helps bring down the hemolytic process. You also get rid of the ultra-large von Willebrand multimers. When you give back donor plasma, that donor plasma has normal size von Willebrand factor, and it has ADAMS13 in it. And so you stop the whole process in two different ways by doing plasma exchange. Before we did plasma exchange, and this was basically discovered in the early 1990s, the mortality rate for this disease was 90%. And so it is not unusual to treat patients for TTP, even if you're not sure whether or not they have it, because you don't want to screw this up. And so there are some diseases like cancer which we will not treat until we're 100% sure the patient has it because of the dangers of chemotherapy. If you suspect TTP, if you're suspicious enough but you're not 100%, we will still put a really large catheter into your neck and hook you up to a machine and take out your plasma and give you a donor plasma because the 90% mortality rate is unacceptable risk to put a patient at. The other thing that we'll do, again, rituximab. This is a monoclonal antibody. MAB is the FDA's way of saying a monoclonal antibody. This is a monoclonal antibody to B cells, and B cells are what secrete antibodies. And this is a way of basically getting long-term remissions or cures for TTP. We will talk about rituximab later on in the week as well. It's kind of funny to talk about malaria here because other than Long Island, I don't think we see much malaria in the United States. I mean, we do see it in a few parts of the southern United States, but malaria kills either hundreds of thousands or millions of people every year throughout the world. And as we all know from the past year, people can come from endemic areas where diseases like Ebola exist and come to the United States. And so it's important when you have a patient with hemolysis to take a travel history. Maybe they've been in a place where malaria is endemic, and here you have the malaria parasite inside of red blood cells, and this ultimately leads to the premature demise of the erythrocyte. And so If someone's having a fever every 96 hours, they've been in an endemic area, look at the smear. This might be what you're talking about. Anyone know where the name malaria comes from? So it's Italian. It's because it's the ancient Romans who noticed people kind of dropping like flies, or like mosquitoes, in the swamps around ancient Rome. And malaria is Latin for mal, bad, aria, air. Because they just thought there was something bad in the air that was causing this disease. I mean, we generally will see this in Africa, in Southeast Asia, but again, it's in South America. You can see in the southern United States and the Mediterranean. The last disease I'll talk about today is very rare, but for reasons that aren't completely clear, it ends up on test questions. A disease called paroxysmal nocturnal hemoglobinuria, or PNH. Urine once again. This disease was observed before, decades before we had any understanding of what was going on. And this is someone's urine throughout the day. This is their urine when they wake up in the morning, and you can see it's very dark, like it has blood in it, and throughout the day it becomes progressively clearer. And so this disease, the original observation is that there were people who had hemolysis, and they woke up in the morning and they had bloody urine, and then throughout the day their urine became progressively clearer. What the heck is this? So PNH basically occurs because of complement, the complement system. If you remember from immunology, it's the complement system run amok. As you know, complement is a system that helps defend the body against bacteria because it's constantly being activated and poking holes into things. It's constitutively activated, and it pokes holes in any bacteria that get into circulation. And this can also happen to our own blood cells as complement is being activated and ultimately forming the membrane attack complex, which pokes holes in plasma membranes. This can happen to our own erythrocytes and leukocytes. And so our own blood cells have developed ways to turn off complement so that they're not destroyed by the complement system. So here's a cell membrane right here, and this cell membrane, this is the outside of the cell membrane, and there are many proteins on the outside of the cell membrane which help cells like red blood cells function properly. And one of the things, and this is called right here the GPI anchor, the glycophosphoinositol anchor. And so this anchor attaches enzymes on the outside of the red blood cell to the cell membrane, and it's anti-complement proteins, which are, when you lose this anchor, you lose anti-complement proteins on the outside of erythrocytes that makes them susceptible to hemolysis. This is how it looks. This is the three different pathways for complement activation. Erythrocytes and other blood cells have two proteins on their surface to defend themselves from constitutive complement activation. One of them is called CD55. It's also called DAF for decay accelerating factor, and that turns off this part of the complement cascade. And there's another protein which again is anchored to the red blood cell membrane by this GPI anchor. It's called CD59, or MERL, membrane inhibitor of reactive lysis. And without these proteins, the red blood cell becomes susceptible to hemolysis mediated by complement. And so they lose these proteins not because they're born without these proteins, but because they acquire a mutation that they lose the GPI anchor, this linker which attaches these proteins to the red blood cell plasma membrane. You're not born with this. For some reason in life, You get a somatic mutation, which means in a mutation that's not from birth, that's acquired in a gene called PIG-A. And PIG-A encodes the glycophosphoinositol anchor right here. When this becomes mutated, it's shut off, and there's over 100 different proteins which can be linked to the surface of a red blood cell that can no longer be linked there. And so they're made, they just get released into circulation. They're not on the red blood cell surface. So what ends up happening is, again, you end up getting hemolysis because complement is always going on, and CD55 and CD59, which are called DAF and MERL again, they're not on the outside of red blood cells, and so the red blood cells get destroyed by complement. And so, for reasons that are not entirely clear, these patients get very brisk hemolysis at night, and it gets better during the day. Complement seems to be more active at night. It may be because there's a respiratory acidosis going on at night, and complement is more active during this period in an acidic environment. But I've had other experts tell me that's not the case. In any case, this is hemolysis that occurs because red blood cells cannot defend themselves against hemolysis. These patients also have a high risk of getting blood clots, thrombosis, and of getting bone marrow failure. So the same markers that are abnormal for other forms of hemolysis, reticulocytosis, elevated indirect bilirubin, elevated lactate dehydration, you're going to see that in PNH. If you see that in a patient who's got a blood clot in their legs and their lungs, or a blood clot in their belly, that's a clue that this patient has PNH. And we don't know why these patients are more likely to develop thrombosis. It's not understood. And it's not understood why they develop bone marrow failure. They end up developing cytopenias, low blood counts. So, about 10 to 15 years ago, a very greedy pharmaceutical company figured out how to stop this from happening. Basically, they figured out that if you stopped complement from running wild in red blood cells, you could stop this hemolysis from taking place. Now, you don't want to shut off hemolysis. You don't want to shut off complement because we need complement. It's there for a reason. And if you don't have complement, you become much more susceptible to infections. And so they basically tried to figure out how they could shut off complement without making people susceptible to infections. And so you want to have enough of complement going on that certain immune functions can go on, but you don't get the membrane attack complex down here. You don't get holes punched inside of red blood cells. And so they figured if they could turn off C5 here in the complement cascade, that this would shut off enough complement that you wouldn't get red blood cell destruction, but you'd have enough of the good things that complement does up here, above the green line, that you'd end up with relatively normal immune function. And so there is a monoclonal antibody called eculizumab. Again, MAB is monoclonal antibody, which binds to CD5 and shuts off complement and basically shuts down PNH from happening. This is the most, I'm not sure. At one point, this was the most expensive medication in the United States. This costs greater than $400,000 a year to treat this disease. So, but it's a very effective treatment. Within weeks of giving this monoclonal antibody, hemolysis should shut off, the risk of thrombosis goes down. Interestingly, I talked about infection. We started treating patients with eculizumab, and then a few patients ended up dying from meningococcal infections. And so apparently this part of the complement cascade is very important for preventing fulminant meningococcemia. So now before these patients are treated with eculizumab, they get immunization against meningococcus to prevent this from happening. Many patients with PNH just need transfusions because they have mild hemolysis. If they develop blood clots, we give them blood thinners. Sometimes we can give them growth factors just to accelerate their production of red blood cells. But if they have terrible hemolysis that they cannot shut down and we can't transfuse them enough, we can't stimulate their body with growth factors to make enough red blood cells, we will give them eculizumab. It is a lifelong marriage. It's given every 2 weeks for life. And again, it breaks the bank. It's more than $400,000 a year. So, hemolysis is when red blood cells are destroyed before their normal 4-month lifespan comes to an end. The first step when evaluating hemolysis is Coombs testing, looking for the antibody. We went over the different simple blood tests which can be used to evaluate hemolysis to see if it's present. And the smear can give you some vital clues. I'll take questions. Yes? So it's an autoimmune disorder that, where that antibody, the immune system gets dysregulated and produces that antibody. Yes. There is an inherited form of TTP. It is where you're born with natural levels of that enzyme. I didn't bring it up because I'm a hematologist and I've never seen a case of it. So I'm just trying to keep it simple. So let's say it's February and it's 5 degrees outside and you go for a walk and all of a sudden you go back inside and your urine is bright yellow or bright red and your eyes turn yellow. So cold avoidance can be a very inexpensive treatment for cold antibody hemolytic anemia. There was a fabled patient where I did residency who basically spent the winter in a city hospital because he had cold antibody hemolytic anemia. So they just kept him there so he wouldn't hemolyze. A plane trip to Florida would have been less expensive. But getting medical treatment in Florida is actually probably much more dangerous. So I'm now going to get bad scores from everybody here from Florida. There's something called thermal amplitude, and so some of these, cold antibodies, some of them are actually are reactive at 37 degrees, but some of them can be reactive at 20 degrees, 25 degrees. So it's kind of how low can you go, and so we are exposed to cold enough temperatures, especially in our digits and in cold weather, where we can get hemolysis. Yes. I think it's mainly expressed, it's probably expressed in other genes, but I'm not aware of the PIG-A gene causing problems in anything other than blood cells, but my suspicion is that it is expressed in other cell lines as well. Do you know, Dr. Duguid?
It is expressed in other cell lines, but because blood cells are so ubiquitous, that's where you see most of the problems.
But again, we don't know why thrombosis, blood clotting, occurs. And it could be, we're looking at the red blood cells and the white blood cells and the platelets. It could be that there's a problem with the lining of blood vessels with endothelium because of the lack of the GPI anchor, and that's why we get blood clotting. Okay, I'll be up here for a few more minutes for other questions. Hey, do you have a USB port on your? It's not a Fitbit, because you're too fit to need a Fitbit.
Rick, where is he?
So the mic is, it's on 2 bars right now. So I think
Oh, that's good.
hours.
No, that's good. That should last the rest of the day. Yeah.
Okay, I'll put these in here.
I'm like, I just put new ones in yesterday. You guys gotta stop eating these things. I know they work for you remote before.
It was constant.
How are you? I remember, yeah. How are you? It's all right. You'll hear a lot about hemoglobin today. No, but that, I'm trying to remember what happened. I think the genetic test came back with the fetal position. How are you doing? Good. Yeah. I will. Yeah, I'll see you later for fun. Yeah, that was fun. Thank you. Good morning. Can we go ahead and get started? Good morning. This morning I'm going to be talking about problems with hemoglobin synthesis and mutations in hemoglobin. Still no disclosures, and you can read these objectives at your leisure. But to remind you that hemoglobin is made up of 4 protein structured, 4 globin chains, and each one has an associated heme group. So there's 2 alpha globin chains and 2 beta globin chains to make this tetramer for hemoglobin, with 1 heme group per globin chain. And the reason for this, we said yesterday, is because iron is such a reactive metal, transition metal going between ferrous and ferric state, that this reactive form, in order to harness the reactivity of that for biologic purposes, the iron is contained within this heme moiety, and heme is the protoporphyrin ring with the ferrous iron attached in the middle. So free iron itself is toxic, free heme itself is toxic, and in order to harness the transition of this iron state for oxygen delivery, the heme is held in the globin chain between 2 histidines. So the heme pocket has this heme molecule with the iron held in this pocket, so that oxygen can come and go into this heme pocket. So that's how oxygen is bound by hemoglobin. So there's allosteric effectors that then will affect this interaction. So normally with hemoglobin, if this is the partial pressure of oxygen, and this is the amount of saturation of the hemoglobin, if you start out with no oxygen and go up to 100% oxygenation, the hemoglobin will be fully saturated. And this is the famous oxygen dissociation curve. And usually we look at about the 50% as an index of 50% saturation, and looking at the partial pressure is around 27 for normal hemoglobin A. These allosteric effectors can shift the hemoglobin dissociation curve one direction or the other. So for example, with acidosis, low pH, or with fever, you have a shifting to the right. This means that the hemoglobin releases oxygen more easily, whereas the reverse takes place if you have a high pH and low temperature. The curve shifts to the left, and this holds on to oxygen more tightly. The other allosteric effector is this 2,3-DPG. And 2,3-DPG, if it's present, allows the release of oxygen more easily. So if you have an increased amount of 2,3-DPG, this will allow the hemoglobin to release the tissue, oxygen to the tissue more easily. And it does this by binding in the central hole of this hemoglobin molecule. So when 2,3-DPG or 2,3-BPG comes into this hole, it allows oxygen to be released to the tissues. Hemoglobin synthesis is the product of genes on both chromosome 16 and chromosome 11. So that the alpha globin genes are on chromosome 16 and they're duplicated. It's interesting that in globin genes that these are expressed lined up along the chromosome and in the order that they're expressed in utero. So that embryonic type genes are upstream here, so that the embryonic alpha-like gene is the zeta gene that's up here, and then you have these two alpha genes down here lower on chromosome 16. For the beta globin, there's only one gene here, but again, the genes are lined up on chromosome 11 in the same order that they're expressed in utero. So the embryonic type of beta globin, the epsilon globin, is here upstream. Then you have duplicated gamma genes. Gamma genes are expressed in utero, so that this alpha-2 gamma-2 is fetal hemoglobin. This is the main hemoglobin that's present in utero. And then in adult life, there's a switch over to hemoglobin A and hemoglobin A2. The delta gene is a gene that's very similar to the beta gene, but the promoter has been mutated in such a way that there's very, very little expression of hemoglobin A2 or delta gene in the adult. So hemoglobin types, you have the embryonic zeta 2 epsilon 2, and the fetus you have alpha 2 gamma 2, which is fetal hemoglobin, and then in adult life you have alpha 2 beta 2, which is normal hemoglobin A. To show you what this looks like with development, if this is the conception, this is birth, and then this is postnatal life, weeks of age, and this is looking at the amount of synthesis of each of these different chains. So erythropoiesis first starts out in the yolk sac, so very early in the first few weeks after conception, you have formation of these megaloblastic cells in the yolk sac, and the hemoglobin in those cells is mostly this epsilon zeta hemoglobin. But very shortly, the erythropoiesis moves into the liver, and as soon as this erythropoiesis moves into the liver, you start having synthesis of this alpha globin. And then alpha globin is necessary through the rest of life. At the same time, the fetal type of hemoglobin, the gamma, alpha 2 gamma 2, starts to be synthesized in this liver hematopoiesis. So that during most of gestation, you have alpha 2 gamma 2 fetal hemoglobin, and then the beta globin, which is the normal adult form of hemoglobin. The beta chain, there's a switchover during the third trimester that completes after birth, where you have a switchover from fetal hemoglobin to hemoglobin A. And you can see that the delta chain for hemoglobin A2 is synthesized in very low amounts, essentially at 0 at birth, and then only 2 or 3% in an older person. Okay. So most of the woes that we have with hemoglobin and hemoglobin synthesis hearken to our long-term evolutionary connection with this Anopheles mosquito. So that if you look at the map of the world, in the ancient world, the areas that were endemic for malaria back in however many years ago, you'll see that a number of different mutations have occurred, which are probably protective against malaria. The implication is that there must be a very potent evolutionary pressure by malaria to give rise to these conditions that do cause human disease. So Dr. Eisenberger talked about G6PD deficiency, which you can see is present in those parts of the world that were associated with malaria. And then two of the conditions I'm going to be talking about today, one is sickle cell anemia, and one is thalassemia. And again, all of these conditions are most likely arose because of our connection, ancient connection with malaria. I like to make a distinction between problems where there's an imbalance in globin synthesis, which is the thalassemias, and the hemoglobinopathies. Hemoglobinopathies is where the actual mutation in the protein, so that you have an abnormal protein that's being synthesized. Whereas thalassemias, there's an imbalance in the synthesis of the alpha versus the beta globin. So just to remind you again that you have 4 alpha genes. Alpha 2, gamma 2 is hemoglobin F, alpha 2, beta 2 is hemoglobin A. And the thalassemia syndromes are such that if you have a decrease in the alpha gene component, then you have an alpha thalassemia. So alpha thalassemia is the most common problem with red cells worldwide. It's extraordinarily common in certain parts of the world. For example, in Papua New Guinea, about 80% of people have a form of alpha thalassemia. In Nepal, about 60 to 80% of people will have an alpha thalassemia. Very common in West Africa, about 30% of people will have alpha thalassemia. So the mildest form of alpha thalassemia, where one gene is missing, and these are gene deletions, so that actually they're not mutations which affect the function, they're actually deletion of the genetic material. But if you're only missing 1 out of 4 genes, you have what's called the silent carrier state. There's very, very little impact on the red cell because you have 3 functioning genes. But this is the form of alpha thalassemia that's so common worldwide. And because this is so common, it's also very common to have 2 genes out of 4 missing, which gives you a 50% decrease in the alpha globin output. So with this 2 out of 4 missing, you do have what's called alpha thalassemia trait. And yesterday when we were talking about thalassemia trait and differential diagnosis of iron deficiency, we said in both conditions the volume of the cells is low, so that the mean corpuscular volume is small. You have microcytic cells. Whereas with that thalassemia traits, you'll have normal hemoglobin, and you'll have a normal RDW, red cell distribution width. So all the cells have the same genetic defect. They're all consistently small. You can also have 2 genes missing in cis. This is 2 genes missing in trans. But when you have 2 genes missing in cis, it has more genetic impact, because in this situation, this person would never pass on more than 1 missing gene to the offspring. Whereas in this situation, you can start to have more clinical impact because can be inherited with more significance. And that's this black region of this map shows where the cis deletion of alpha genes occurs. So it's only in certain ethnic populations where you have this risk for serious alpha thalassemia. And those are parts of the world like in the Mediterranean or in Southeast Asia, where you have both genes, a possibility of both genes being deleted on the same chromosome. So to go through it again, alpha thalassemia is where you have decreased alpha synthesis. In the thalassemias, the imbalance, the problem is actually caused by an overexpression of the other globin gene. So if you're not making enough alpha, the problem is not that you're not making enough alpha, the problem is that you're making relatively excessive amounts of either gamma or beta chains. So in alpha thalassemia, if you're not having enough alpha, in utero life you'll have gamma-4 tetramer, which is called hemoglobin Bartz, and then after birth you'll have the beta-4 tetramer, which is called hemoglobin H. And these are unstable hemoglobins. They will circulate, but they don't function very well in oxygen delivery. So they're hemoglobins that cause hemolysis. That means that they are synthesized and are in the red blood cell, but they cause hemolysis rather than decreased production of red cells. So again, hemoglobin H disease, where you have hemoglobin H as a beta-4 tetramer, when you have only one remaining functioning alpha gene, these people are able to survive with the hemolytic anemia because they do have one functioning alpha gene, but they have an increased amount of the beta-4 tetramer or hemoglobin H disease. And they have a hemolytic anemia that's approximately as serious as hereditary spherocytosis. It's a chronic hemolytic anemia. On the other hand, if you have all 4 genes missing, this is incompatible with life. Remember, you need the alpha gene very early in utero development in order to pair with the gamma chains. So that if you're not making any alpha, you start having damage to the fetus very, very early in gestation. So that hydroxyl fetalis usually results in miscarriage during the 2nd or 3rd trimester. This is the hemoglobin H prep, which is similar to what Dr. Eisenberger was showing with the Heinz body. This is precipitated hemoglobin. It just shows you that the hemoglobin H is unstable and it will precipitate in the red blood cells. When you look at the smear with hemoglobin H disease, you'll see target cells. You'll see polychromasia that's more bluish. Red blood cells indicate that there's an increased reticulocyte. So hemoglobin H disease is a hemolytic anemia, but it is not a severe disease. On the other hand, beta thalassemia, there's only 2 functioning beta genes, so that you either have both working, one working, or none working. So that if you have one out of the 2 beta genes that are disordered, and beta thalassemias are usually not deletions, they're usually mutations which affect the function of the beta gene. And with beta thalassemia trait, again, like alpha thalassemia trait, you have a normal hemoglobin hematocrit, but you have a low MCV and you have a normal RDW. With beta thalassemia trait, you see these microcytic cells. You don't have a cell for comparison, but small lymphocyte is about the size of a normal adult red cell. So you have these microcytic red cells. You'll see elliptocytes, and you'll also see target cells. This is beta thalassemia trait. And you would see a similar picture with alpha thalassemia trait with 2 alpha genes missing. So with beta thalassemia, you have decreased beta synthesis. The difference is that with the alpha thalassemia, you have overexpression of the beta and the gamma, which form unstable hemoglobin. In beta thalassemia, you have overformulation of the alpha-4 tetramer. And alpha-4 tetramer is such a toxic entity that it actually causes destruction of the red blood cell within the bone marrow. So the difference is alpha thalassemia syndromes or hemolytic anemias where the red cells get into the circulation and can survive, whereas with beta thalassemia, the red cells are killed within the bone marrow, and this results in what's called ineffective erythropoiesis. The red cells just aren't released from the bone marrow. And in order for these patients to survive, beta thalassemia presents usually during the first year of life. In utero and in the first months of life, they're protected because of fetal hemoglobin synthesis. So once you have a switching over from fetal synthesis to normal beta globin synthesis, this is when the beta hemoglobinopathies and beta thalassemia starts to present. So usually by 1 year of life, in order to survive, these individuals will need regular transfusion. Just to show you a smear, they have these bizarre red blood cells, target cells. You'll see, because of ineffective erythropoiesis, you'll see nucleated red blood cells in the periphery. Bone marrow is trying to make as many red cells as possible. You'll see Howell-Jolly bodies. In terms of the consequences of ineffective erythropoiesis, if the patient is not transfused, this bone marrow tries to expand wherever it can. So wherever there's bone marrow in the body, this will expand in order to try to produce as many red blood cells as possible. So that extends into the calvarium, so that you have this as a regular skull x-ray, you'll see this expansion of the bone marrow to cause this hair-on-end appearance, this crew-cut appearance of the skull. And if you look at an MRI, you can see the expansion of this bone marrow within the skull, which is not a normal place for bone marrow to expand. You can also see the same thing in the long bones, get very washed out because the bone marrow is just trying to expand as much as possible. So in order for these individuals to survive, they need to be put on a regular transfusion program. And what was discovered in the 60s is that they will do much better, people will have a much better quality of life if you transfuse them up to a hemoglobin of at least 10 to 12. So if you keep them at a hemoglobin that's relatively normal, then this prevents a lot of the complications like this bone expansion that would ordinarily happen with somebody with thalassemia. On the other hand, as we learned yesterday, whenever you give red blood cell transfusions, you bring iron into the body. There's no normal egress from iron from the body, so that the only way to get rid of iron from these patients is to give them chronic chelation treatment. This can either be parenteral or now there's oral forms of iron chelation that can maintain iron balance in spite of transfusion. Just to remind you, one other thing from yesterday is that we said that stress erythropoiesis, like in thalassemia, triggers erythropoietin, which downregulates hepcidin production. So then in patients with thalassemia major, even though they're anemic, their hepcidin level is inappropriate low. So that means that the iron can just come into their body even though they're anemic and iron overloaded. Because of the stress erythropoiesis that's going on, they actually have iron overload and they'll continue to absorb iron. So the main problem with thalassemia major in this day and age is really with problems with iron overload, very similar to hemochromatosis. So this shows you the situation where you have iron overload. At the bottom, the red line is the normal amount of hepatic iron. And we use liver biopsies and hepatic iron to follow iron overload because serum ferritin, being an acute phase reactant, it's not a very good measure of the total iron burden for the body. Whereas you can either do a liver biopsy or now there's MRI techniques where they can look at the quantity of iron in the liver, and the liver iron is a good reflection of how much iron there is in the whole body. So if you look at an untreated patient with thalassemia major, you can see that very quickly these patients start on transfusion by 1 year of age, and you can see that by 5 or 10 years of age, they have extraordinarily high levels of liver iron. This is the threshold for disease. Cardiac disease is usually iron going into the conducting system of the heart and actually causing arrhythmia. But it also, iron goes to every organ of the body, can cause widespread problems, whatever organ it's involved in. So without chelation, you can see that thalassemia major is a huge problem with iron overload. Yesterday we talked about homozygous hemochromatosis. These are the genetic forms of hemochromatosis that are as a result of a dysregulation of the hepcidin pathway. Remember, these are mutations like in HFE that are involved with the regulation of hepcidin in the body. And in genetic hemochromatosis, you're not making enough hepcidin, so the iron just comes flowing into the body from dietary sources. So untreated people with homozygous hemochromatosis, you can see that in early adulthood, they would start to have clinical effects of the iron overload. And we said yesterday that the treatment for hemochromatosis is regular bloodletting or blood donation to get rid of iron from the body. With iron chelation, you can hopefully contain the iron overload to an unclinical amount, but you can also see that patients, even patients with heterozygous hemochromatosis, had some predisposition to iron overload. Okay. The next condition I'm going to talk about, switching from the thalassemias, which are problems with imbalance in hemoglobin synthesis, I'm going to be talking about the hemoglobinopathies, which are mutations in the globin chains themselves. This is from the original paper in 1910, where this phrase was coined. This was in a dental student in Chicago was realized when they looked under the microscope that they saw these sickle red blood cells present in his peripheral blood. Again, just to remind you, here's endemicity for malaria. You can see that sickle cell mutation arose in 5 different population groups in the ancient world. So it arose in 4 different population groups in Africa, and then a population group in Saudi Arabia and India. And you can see what the incidence is particularly high in West Africa for sickle cell. Sickle cell has been called the first molecular disease, because this is the first disease where they indicated that there was an abnormal protein that was formed that caused the problem. And this was initially demonstrated by doing a hemoglobin electrophoresis. So if you put hemoglobin in this supportive medium and run it, these are the controls, depending on the charge of the hemoglobin, they'll separate electrophoretically. So normal hemoglobin A will move here, hemoglobin S moves here, and hemoglobin C moves here. So that this patient, the original patient in 1948, they discovered that the reason for the sickle formation in the red blood cells was that this patient only had this abnormal form of hemoglobin, the S hemoglobin. There's no hemoglobin A. So this is homozygous SS. This is normal hemoglobin A. Nowadays, instead of doing an electrophoresis, we use HPLC, high performance liquid chromatography column, in order to separate hemoglobin. The advantage of this is it's both quantitative and qualitative. So it both tells you that the protein is running in a different place, but the area under the curve is quantitative, so you're able to quantitate the hemoglobins as well as identify the variation. So again, it starts down here, and the hemoglobins come out of the column in this order. Here's the controls. Here's hemoglobin F, A, A2, and S. These are just controls, so the proportion is not relevant. And this is the test that's now done to detect newborn babies with sickle hemoglobin, with hemoglobin SS, so that they do an HPLC column on all newborns in New York State and most states in the country. And what you'll see in a newborn with sickle cell disease is that they have only hemoglobin S and hemoglobin F. Hemoglobin S is a mutation in the beta globin, so you still have a normal fetal hemoglobin. And in the newborn screen, you'll have only S and F, and there's no hemoglobin A. So this is homozygous sickle cell disease. The sickle mutation is on the number 6 position in beta globin, so that the codon is mutated from a GAG to a GTG, and the normal glutamic acid is replaced by valine on the number 6 position of the beta globin. What that means is that you're replacing a charged amino acid with a hydrophobic amino acid. So that usually the hemoglobin molecules are very tightly packed inside the red blood cells. They're all like right next to each other. But because of electrostatic repulsion, the glutamic acid prevents the hemoglobin molecules from sticking together. If you have that mutation, what happens then is when oxygen is released from the hemoglobin molecule opens up. And when it opens up, it exposes this valine, this hydrophobic patch. And what can happen then is that these hydrophobic patches, the hemoglobin molecules, can stick together. They make first these clusters, and then it's thermodynamically favorable for them to elongate into these long, long fibers. And this can go back and forth. So with deoxygenation, you have this fiber formation, and then with oxygenation in the lungs, you have it revert to the normal oxy configuration. These long fibers of the sickle gel then elongate into a long tubular structure, and what you see then in the peripheral blood is the sickle cell. It's all the fibers aligned into this one long channel that then distorts the red cell into this sickle shape. What's this thing right here? So that's a bummer, right? If you have sickle cell, it's supposed to protect you from malaria, and then you can still get malaria with sickle cell disease. So this is just to show you that even though genetically and evolutionary-wise, malaria, sickle cell disease protects you from the more severe forms of sickle cell or lethal forms of sickle cell. If you have sickle cell disease or sickle cell trait, you can still get malaria. Okay. The primary clinical manifestation of sickle cell disease is vasoocclusion. So that the main thing that happens is a plugging up of the blood supply to various organs. And this is initiated in the postcapillary venule. What happens is that these sickle red blood cells stick to the postcapillary endothelium, which is not seen in normal hemoglobin A cells. So that you have these red blood cells sticking to the postcapillary venule. You have the input of polys, so that you have the inflammatory white cells that then come to the area. And then you have a secondary trapping of these sickled red blood cells. So what eventually happens is that you have a plugging of the postcapillary venule, and that spreads to the larger vascular supply. There's other factors involved with this as well. Dr. Eisenberger talked about ultra-large von Willebrand multimers. Those are implicated. White cells are implicated. Platelets are implicated. Cytokines are implicated. So this is, even though sickle cell disease is a single genetic mutation, a single amino acid substitution, it has widespread implications for the rest of the body, including all of these other factors that result in vasoocclusion. When vasoocclusion occurs in the bone marrow, it causes pain because you have fibers in the bone marrow that are extremely sensitive to pain. So that when you have bone marrow infarction in the bone marrow, this results in swelling and pain. In children, early children, this results in dactylitis because the bone marrow in children is in the small bones of their hands and their feet, so that when they have bone marrow infarct in their hands and their feet, they develop this painful crisis of dactylitis. Later on in life, in adolescence, the bone marrow moves to the long bone, so the typical painful crisis for adolescents and adults with sickle cell disease is pain in the spine or in the long bones, is where the bone marrow is. The other feature is that Dr. Eisenberger talked about the spleen as being the site for removal in extravascular hemolysis. So with the sickle mutation, you have a very shortened red cell lifespan. These red blood cells are stiff and they're very quickly removed by the spleen. They're also toxic to the spleen, so that because of sickling within the spleen, very quickly you lose splenic function. So even by 6 weeks of age, you can lose splenic function if you have sickle cell disease. This is one of the reasons that sickle cell disease is one of the diseases that's screened for in the newborn screen. You want to know as early as possible whether the child has sickle cell disease so you can start to intervene. And the most important intervention, this is just for completeness, this is a Halley-Jolly body. It's a piece of the nucleus. Usually when the red cell leaves the bone marrow, it leaves the nucleus behind, but you can have a little piece of the nucleus that circulates with the red cell. And usually the spleen would pit this out the first time the red cell goes to the spleen. But if your spleen's not working, then you have Halley-Jolly body persisting. The splenic damage that's done by sickle cell is that it decreases the opsonizing ability for specific bacteria. So it causes a defect in opsonization of encapsulated bacteria. So there's specific bacteria like pneumococcus, strep pneumo, Haemophilus influenza, Neisseria meningitis, and Salmonella. These are the organisms that cause the most problem for patients with sickle cell disease because their spleen is not protective. Fortunately, we have immunization against the first three of these, so that as soon as the child is old enough, they can be immunized against these three organisms. The other thing that happens with the spleen is that for reasons we don't understand, sometimes in young children, all of the blood volume will just pool in the spleen. The spleen, in the early years of life, it's full of, it's enlarged because of the chronic hemolysis that's going on there. And for reasons we don't understand, sometimes in a 1 or 2 year old child, the spleen will all of a sudden rapidly enlarge and the blood volume will just pool in the spleen. And splenic sequestration can be a lethal complication of sickle cell disease because they have a very severe anemia that develops very, very quickly. Something similar happens with the penis in later life, because you can have priapism, which is a very similar kind of thing where you just have sudden pooling of the blood in the penis, which can then cause problems with fertility later. Another main complication of sickle cell disease is acute chest syndrome. So we know that patients with sickle cell disease are more prone to certain bacterial infections, and also with sickle cell disease causing infarct of the bone marrow. With infarction of the bone marrow, there's release of fat into the circulation, so you have fat emboli that go to the lungs. So whatever the initiating event is, if you start to have a new infarction or infection in the lung, say if you start out either with a pneumonia or if you start out with a fat embolism in the lung, because this infarction causes a decrease of blood supply and hypoxia to that region, this is a setup for further sickling. So with acute chest syndrome, you have an initial nidus of hypoxia, acidosis, and higher temperature, and then you can have sickling of the surrounding vasculature, so that what happens is that you have this very rapid spread from an isolated lesion to white out of the lung. So acute chest syndrome is a vicious cycle of infarction and infection that is also one of the main causes of mortality in sickle cell. Speaking of mortality, this is a study that was done for 10 years in 78 to 88 in this country. It was a cooperative study just looking at the long-term survival and complications with sickle cell disease. And this shows you the probability of survival of individuals with sickle cell disease versus black males and black females. So that you can see that men and women in a similar population group, this is their survival, whereas with sickle cell disease, their lifespan is curtailed. So that the 50% or the median survival for patients with sickle cell disease is somewhere in their 40s or 50s. And this was using therapy which was standard in 1978 or 88. There's been some improvement in survival since that time. And this shows you the increase in life expectancy with time. So I think the first main thing that allowed for prolonged survival was a recognition that if you give regular penicillin treatment, starting very early, like a month of age, you start giving penicillin treatment, this will protect against the pneumococcus. And this in combination with an immunization against H. flu, pneumococcus, and meningitis has led to an impressive increase in the survival of people with sickle cell. So this is, again, one of the reasons that newborn screening is done, so that penicillin can be started as soon as possible and these individuals are immunized appropriately as soon as possible. More recently, hydroxyurea has started to cause an increase in life survival. And even more recently, we're realizing that by preventing stroke in sickle cell disease, that we can improve the life expectancy. And then more recently, just a few years ago, it was realized that children will benefit from hydroxyurea starting at a very early age. And we'll talk more about hydroxyurea. This is a dramatic study, a very small study, but it was done in Greece in looking at patients with sickle cell disease, either receiving hydroxyurea or not receiving hydroxyurea, and showing the survival. You don't get this kind of effect in most studies, but this was a dramatic study in a small study in Greece that did show that hydroxyurea treatment is actually associated with a prolonged survival. What does hydroxyurea do? One of the main effects is that hydroxyurea induces a stress erythropoiesis and causes red cell production to switch back to fetal hemoglobin synthesis instead of hemoglobin A. So that by increasing the fetal hemoglobin doesn't participate in the sickle fiber formation, so that fetal hemoglobin is protective against sickling. You know that newborn babies with sickle cell disease don't have any problems because they have fetal hemoglobin, which prevents the cells from sickling. So it switches the patient back to a more fetal type situation. It decreases the number of neutrophils. Hydroxyurea is a chemotherapeutic agent, and one of the ways we use it is we push it to maximum tolerated dose by looking at the white count. Because if you reduce the white count and the cytokines, if you remember that vaso-occlusion involves neutrophils and cytokines, if you reduce the white count, you have less incidence of vaso-occlusion. It decreases the adhesion molecules in the endothelium that are responsible for vaso-occlusion. It causes a macrocytosis and increased hydration. So that, remember I said that in the red blood cells, the hemoglobin molecule is very tightly packed in the red cell. If your red cell is dehydrated, if you have loss of cell water, the molecules are jammed in even tighter. Whereas if you have an increase in the cellular water, if you have macrocytosis and decreased hemoglobin concentration, then you'll have less tendency for sickling. So hydroxyurea has this effect. And also hydroxyurea actually generates nitric oxide production. Nitric oxide is essential in the regulation of the vasomotor stability. It causes vasodilation. So hydroxyurea is one of these drugs that was originally used because it was recognized that it could increase the fetal hemoglobin. But since its recognition, we realized that it's one of these drugs that has many, many different good effects on sickle cell disease. Another advance in the treatment of sickle cell disease was the recognition that stroke is a very common complication of sickle cell disease. And rather than being a plugging up of the capillaries in the periphery of the brain, sickle cell causes endothelial damage in the large arteries in the circle of Willis. So with sickle cell disease, the main pathology is actually a vasculitis and stenosis of the large arteries around the circle of Willis. So it was recognized that by doing transcranial Doppler, if you use a Doppler probe and look at the flow of these arteries around the circle of Willis, what happens is as the arteries become more stenotic, you have an increase in Doppler flow. So that with the narrower vessel, you have an increased flow. I guess that's Bernoulli's principle. And then when they looked at the children who had high flow through those arteries, they did a controlled study using a cutoff of high flow. And children who had high flow, they were either randomized to regular or standard treatment for sickle cell, or they were randomized to transfusion. Red blood cell transfusion, because you're replacing the blood with normal hemoglobin A, it prevents all of the complications of sickle cell disease. It gives you iron overload, but it prevents the sickle cell. So with transfusion, what they found was that very few of these patients with high flow went on to have a stroke, whereas a lot of the ones that were not given transfusion went on to have a stroke. So this was a study that was terminated early when it was recognized that transfusion made a dramatic impact in terms of the number of strokes. Unfortunately, when it was then tried to stop transfusion at some point, so all these patients with high flow were then put on transfusion, then we started thinking, well, after a few years, it should be okay to stop the transfusion and the problem will be over. But unfortunately, in the STOP2 trial in 2005, you see that with cessation of transfusion that you immediately have a big increase in strokes. So currently, research is being done to see if there is any way to stop transfusion once it's started. And one possibility is to use hydroxyurea, which is being studied now. Another effect of sickle cell disease is pulmonary hypertension, chronic lung disease causing hypertension to the lung. And this is, you can measure this by looking at the tricuspid, by doing echocardiography. And if you have regurgitation across the tricuspid valve, this is an index or an indication of pulmonary hypertension. And pulmonary hypertension is one of the most lethal complications in adults with sickle cell disease. So this was a study that was published in 2004 that looked at the amount of tricuspid regurgitation, so that if there was very little tricuspid regurgitation, these patients went on to have, and this is actually survival, went on to have a pretty normal survival. Whereas sickle cell patients who had a significant amount of tricuspid regurgitation had a very poor survival over the next 3 years, indicating that pulmonary hypertension, as manifested by this tricuspid regurgitation, was a real problem in patients with sickle cell. So that's basically the important complications of sickle cell disease. But the other condition that's also very common, this is, as you remember, this is normal hemoglobin A, this is hemoglobin S. People who are heterozygous for sickle mutation, they have one normal gene that's making hemoglobin A and one gene that's just making hemoglobin S. So more or less they have about 40 or 50% sickle hemoglobin or 40%, 50% of hemoglobin A. And while this is a largely benign condition, it's gotten some news notoriety lately because of this mandate by the NCAA. I think now all college athletes now have to be tested for sickle cell trait. And the reason for this is that there were some very high-profile incidences where there was sudden death on a basketball court or in a sporting event because somebody with sickle cell trait was found to have had sudden death. And the idea is that there's possibility that in extreme conditions of dehydration and stress that you could actually have sickling with sickle trait. It's not exactly clear that that's actually what happened, but more rationally than to test every single person in college sports is to just let people drink water and like have water available for training and to make sure that you have free access to water and that you don't dehydrate during training. And with good hydration, this shouldn't be an issue. Okay. The next hemoglobin I'm going to talk about is hemoglobin C. This is another hemoglobin that is probably protective against malaria. It arose in northern Ghana, and it's the same number 6 position. But instead of making, in the beta globin, there's a mutation in the same number 6 position in the beta globin and hemoglobin C. But instead of making the long fibers that you see in sickle cell, with hemoglobin C, you have this formation of these tetragonal crystals. What happens then is that hemoglobin C homozygous is not really problematic. People that are homozygous for hemoglobin C have very little impact. However, hemoglobin C can participate in the sickling with hemoglobin S. So if you have one gene that's making S and one making C, you'll have a sickle cell disease that's of a milder phenotype than homozygous SS. And with hemoglobin C, you have formation of this crystal in the middle of the red blood cell. So you have very striking target cell. You have coffee bean cells and sugar cane cells. So hemoglobin SC is important just because hemoglobin C came from the same part of the world, and hemoglobin C interacts with S to cause a form of sickle disease. So I've said that thalassemias are imbalanced between the alpha and the beta globin synthesis, and you have a problem because of the excess formation of the other unpaired globin. And hemoglobinopathies are like hemoglobin S and hemoglobin C, where you have a mutation in the globin protein itself that then causes problems, changes in the physical characteristics of the hemoglobin. The last thing I want to talk about is where you have a situation where both things are present. And hemoglobin E is a mutation where you have decreased synthesis of the hemoglobin E, but you're also synthesizing an abnormal protein. So it has features of both a hemoglobinopathy and a thalassemia. The reasoning I'm bringing it up is that some people say that hemoglobin E is the most common hemoglobinopathy in the world. It's extraordinarily prevalent in Southeast Asia. Something like 40 to 60% of people in Laos have hemoglobin E. So even though we don't see it as much in New York City, hemoglobin E worldwide is a huge problem. You see it in Bangladesh and Southeast Asia. And with hemoglobin E, the mutation is in the exon 1, it's the number 26 position. What happens is that it causes a substitution so that you have an abnormal protein being formed with the substitution, but it also creates an abnormal splice site so that the hemoglobin E is synthesized in much reduced amounts. So if you look at the HPLC column, here's hemoglobin A and here's hemoglobin E. You can see that the E in this patient with hemoglobin E trait is in much less amount than the hemoglobin A. So the hemoglobin A actually results clinically in something that's more like a thalassemia trait. So patients with hemoglobin AE have a low MCV. They look like thalassemia trait because of decreased synthesis. It's only clinically relevant when you have hemoglobin E on one beta gene and beta thalassemia on the other one. Because of the decreased synthesis of this protein, you have what's called a thalassemia intermedia type picture. Thalassemia major is where you require a transfusion in order to survive. Thalassemia minor is thalassemia trait, and thalassemia intermediate is where you can survive with that transfusion, but not very happily. So this is an example of hemoglobin, thalassemic hemoglobinopathy that causes both an abnormal protein and a thalassemia type phenotype. I think that's everything we talked about. Any questions? Questions from yesterday? Thanks.
Good, how are you?
Well, thanks. I'm Ashley Kingen with CCNMTL.
All right, let me do this. Let me see if this works.
Did you set up a reserved ID?
I did not, so I'm going to get an ID right now and just write it up on the board.
Let's get you a reserve ID really quick.
Okay. Hi, what's up?
This is going to be an audience response.
You want to sign in really quickly with
So
your?
so I'm not sure my ID works. I tried to do this morning.
Have you set up an account before?
I don't have a cloud account.
So
I have a.
if you've got a Columbia account, then it should work. So
I
in other
tried
words, you
this
can log into
morning.
Turning Point.
Let's see if it works. Okay.
Okay, so click connect. Sign in. And now we can come down to reserve. And this will be yours forever. So you might want to use something like Dr. E or
Oh, I can. This is my ID forever.
This can be yours forever. I wouldn't if you. So you could use the course ID, but then you're gonna steal it from everybody else. So something easy that they can.
Okay.
Let's do no spaces.
Fine.
And then we can reserve. So what this does is it means that if you can.
Why do you have to use a Mac?
And we'll set you up with one in a second as well.
All right. So now, hold on. Let me. You know what? So let me log in. Let me pull this. Let me
If
just
you
open up my.
want to sign in so long, and then we can set you up with one as you go.
This is my regular
This is how you'd sign into Turning Point. So it's generally your email address. It's what you probably set up with Angie.
I don't think I ever set up a password. That's the thing. So I'm going to do that tonight.
Okay.
So let's check if it's the right email address first.
So.
So I don't think you have an account yet.
Let me just I can do that.
So David,
Yes?
this is how you log in. You know, you're going to click
Right.
over here for a receiver, your username, your password, and then you're going to use.
And one more step. So let's do not prompt participants to enter user information. So allow guests allows them to enter as a guest, but it still asks them to put in their information.
Okay.
I'm actually curious as to if the capitalization of that matters.
You can try.
So I'm in.
Okay.
If you don't mind, quickly, let's go to your first question and make sure that it pops up here for me. And so then I get it to pop up here, and I can choose my answer.
Okay. Did
And
you
if-
respond?
So let's hit something now.
There we go.
So now you have one response.
Okay.
Yep.
Okay.
So now because we did that, we should clear the session again. Or you can go back to just that one slide and just clear that one slide. So we can do the reset up here and reset slide.
Okay. Okay.
And then so if anything happens where it comes up and students are going, oh, I can't get on anymore, you jump
Reset
back
the
out
session.
and sign back in or make sure. Exactly.
Okay.
And I have to run shortly, but I'll stick around for about 5 or 10 minutes to make cross our fingers that nothing goes haywire, and then you should be good to go from there.
Thank you.
All right, I got you to the screen.
Great.
And all right, can I just use my email as the
Yeah.
All
That's
right.
the easiest to.
select a role? Instructor, I assume. I have to put in a password, I guess. All right, so it looks like I now have an account.
Let's just make sure that you're showing up here for me. I'm not seeing you. It might just take a minute to update. Why don't you try signing in with the
I actually.
Okay, so that looks like it's working. And
So this is going to be mine.
yeah, this can be yours for forever.
All right. Do the caps matter as far as?
They don't, but you can leave them as caps. Yeah.
All right.
Yep. Great. So this is yours now when you go to
Okay.
actually
All right.
sign in.
All right, we're gonna get started.
Great. And yours is tomorrow, correct?
Right.
Buenos dias.
Angie or I will be here for at least the first 10 minutes to help you sync.
Yesterday, Betty probably also, in addition to everything else that was posted, I sent some morphology slides, just looking at basic blood smears. We will go over that at some point together. We might do it today. It just depends on how much time. I was going to do that first, but since Turning Point has been misbehaving, and the Turning Point guy is here, we're going to start with the audience response session, and if there's time at the end, we'll look at some blood smears together. This up here is the login for this. So these are mostly case-based questions. Right here. I'm too loud? No, it's okay. I'm told it doesn't make a difference whether or not you capitalize it. So this is a case of a 50-year-old woman comes in with weakness and dizziness. Her only past medical history is asthma, and she had pulmonary tuberculosis 15 years ago. Asthma is pretty well controlled. She uses a pump. Sometimes she needs steroids when she has a severe asthma attack, and it's because she has not gotten rid of the cats that make her asthma worse. And this is very common. You take a past medical history. She was traveling in Southeast Asia 15 years ago, and she got the classic symptoms of pulmonary tuberculosis, and she was treated with the 4-drug cocktail, and she was anemic at that time, and so she got iron as well, and she recovered fully at that time. And you're reviewing her medical record, and this is what you find from 15 years ago. This is what her blood counts looked like, say, in 2000. And the question's going to be based on these labs. I'm going to go back and forth between the question slide and this. Anemic, slightly low MCV, slightly above normal retic count, white blood cells high, high bands, high platelets. I'll let you look at this, and then I'm going to go back to the labs, and then I'll go back to this. All right, never mind. No, we're getting responses. Yeah.
Flip slides, it closes the polling, so you only get...
Oh, so how do I... That didn't happen before.
I think for this one, we should just let...
All right. Now you see the right answers on me.
You go from that slide. Yeah.
Well, now you've all seen the right answer. Okay. So, half of you were saying that the elevated reticulocytes show compensation for anemia, and about half of you were saying that the elevated platelets are a reaction to infection. So we haven't gone over this yet, but again, we're looking at some of this yet, but we're looking at what's not true here. And platelets are an acute phase reactant, which you've learned about before, so those are going up just like the white blood cell is going up because you have an inflammatory response and you have an infection. Looking at the reticulocytes here, just going back, the reticulocytes are 2%, which is a small increase. And so what you need to appreciate is the more anemic somebody is, the higher the reticulocyte count needs to be. And so in this patient right here with a hematocrit of 26, which is probably like a reduction of a third of a normal, from a normal hematocrit, the reticulocyte count should be much higher than 2% right here. So this would kind of constitute an insufficient response to anemia here. And again, platelets, bands, and neutrophils, these are all things that can go up in response to an infection. Someone was asking me after the first session whether or not the bands are actually effective in terms of fighting infection, and the answer is yes, they are. These are effective white blood cells in fighting an infection, and they come out of the bone marrow earlier than they're supposed to because the body's trying to do everything it can to manage the infection. So here the incorrect answer, which is the correct answer, is that this patient is not fully compensating for anemia. So C is the wrong answer, so to speak. Questions?
Is this slideshow available?
I haven't posted it yet, but I think we can post it after this. In the back. She's not compensating sufficiently. Yes, the elevated, when reticulocytes go up, when you have reticulocytosis, it shows that the body's trying to compensate. In this case, what happened in this particular case is what Dr. Hart was talking about yesterday. You have anemia of chronic disease, anemia of chronic inflammation. The inflammatory response that the tuberculosis engenders prevents the body from reacting sufficiently from making new red blood cells. These are the iron studies, as we call them, from when the patient presented 15 years ago. You might want to write these down, since I can't go back and forth. And the question that follows how do you interpret these iron studies? Again, I'll regurgitate. The serum iron was 20, which was low. The serum iron binding capacity was 200, which was low. The iron saturation was 10%, which was low. And the ferritin was 400, which is high. So this is actually reflective of your peers. This is something that this is something which is difficult even for residents and for trained doctors to appreciate, because most of you have gotten this wrong, which is not surprising since you just learned it yesterday. So importantly, most of you said low iron saturation reflects iron deficiency. Can anyone explain why that might be the case or why that's not the case? Or should I just do the talking? All right. So the serum blood test for iron, the amount of iron that's in the blood, is the worst test for assessing whether or not someone has enough iron in their body. And the reason for that is, if you are iron deficient, you will have low iron in your blood, but if you happen to have an iron pill or a steak right before that blood test, it can go up falsely. But more importantly, The second most common anemia that we see other than iron deficiency is anemia of chronic disease. And the whole purpose of anemia of chronic disease is when you have inflammation, and that inflammation sequesters iron out of the blood. So when you're trying to differentiate anemia of chronic disease from iron deficiency, the serum iron level will not help you differentiate them because you'll have a low iron in both of those conditions. And so A is not correct because you don't know whether or not the patient actually has lower normal or high iron stores because the serum iron test is really not a meaningful test by itself. Iron saturation by itself, which is iron divided by iron binding capacity, is not such a good test for looking at someone's iron stores. And because it really depends on, because the iron binding capacity will go up in iron deficiency, but it can be suppressed in anemia of chronic disease. This patient had low iron binding capacity because she had an inflammatory disease. And so the 20 divided by 200 gave you a 10%, which is a low iron saturation, but both the iron and TIB were suppressed and won't give you an accurate measure of the total body iron. The most accurate measure of the amount of iron in body is ferritin. And the higher the ferritin goes, the more likely someone is to have enough iron in their body. And once you go beyond the normal range, it's almost impossible to become iron deficient. And so the correct answer here is B, because in this case, the ferritin was 400, which is above normal. Again, don't look at the low iron, A and E, because it won't really help you, because you can't look at low iron in the blood by itself. Iron saturation is only useful in iron deficiency. In an iron deficiency, you want to see low serum iron and high iron binding capacity. And here the iron binding capacity is suppressed because of the anemia of chronic inflammation. Yes?
If you have some sort of mutation in ferroportin, would you have elevated ferritin but still be iron deficient?
If you had a mutation in ferroportin, it would depend on the mutation in ferroportin. If you had a mutation, these are very rare things. I mean, you could have a mutation in ferroportin that prevents it from being degraded by hepcidin, and then you'll take up too much iron in the body.
Like dysfunctional, or like overactive hepcidin?
So there are rare mutations in hepcidin where it doesn't function properly, and then you'll get iron overloaded. And the iron in your blood will be high, and your ferritins will be very, very high. This is, mutations, and I've never seen a patient with a mutation in hepcidin. This is, we know that they exist, but they're rare diseases. These are difficult tests to interpret. I mean, the house staff does not get this right. So this is just straight out of Dr. Hart's lecture yesterday. So, the plurality of you got this right. It's ferritin. Ferritin is an acute phase reactant, and it also is a protein which is used to store iron inside of blood cells. Erythroferron is secreted by red blood cell precursors in the bone marrow, and this basically antagonizes, does the opposite thing. Erythroferrin gets rid of hepcidin and allows more iron to be absorbed in the body. Transferrin, like trans, across, and ferrin, iron, or here like ferry to carry, transferrin carries iron in the blood. ferroportin, port is another way of saying carry, basically is a protein which allows the gut to absorb iron. And hemojuvelin is one of the proteins which also allows iron to cross cells. But ferritin is increased in inflammation and is part of the iron sequestering process.
Could you give us like a timer or something so we know when you're going to close the poll?
Sure. Or I'll warn you. I usually wait until I see about 30 responses or so, but I'll warn you. All right, 10 seconds. Good. So most of you just kind of took the piece of information that I gave you and used it. Again, when you see a very high ferritin, you can feel very confident that the body's iron stores are replete, and so there's no need to give iron supplementation in that case. Ignore the serum iron. By itself, it doesn't really tell you much about the body's iron stores. It basically just tells you about the patient's last meal. So that was 15 years ago. This is the patient's labs today. Questions will follow, so while you're thinking about this again, TIBC is elevated, it's 475. Serum iron was low. The iron saturation was 1% and ferritin was reduced. Ooh, 10 seconds. Okay. 60 seems to be the max here. Good, good. So you don't really see changes in neutrophils with iron deficiency anemia. They become hyperchromic because you don't have enough iron around to make hemoglobin, which is red, and they're small, they're microcytic. This is the classic finding right here. Where's my pen? Normally what you should do is, the way to look at this is you basically look at the diameter of a red blood cell. And about 1/3 of the diameter should have central pallor in a normal red blood cell. And if you look at a cell like this, you can see that more than half of the diameter is pale. And so, that's, in my mind, to my eyes, this is, kind of rip-roaring iron deficiency anemia. To me, these cells are small, and that's something that you can really only get, with experience. But this and this, maybe you can see that some of these cells are small. You can compare them to the nucleus of the lymphocyte as kind of a bit of a basis for comparison. Wouldn't be surprised if Dr. Garrett pulled something like this on the exam. Not that I'm a prophet. So before we go on with the case, going back to the white blood cell counts and to the lectures yesterday, she's come in for dizziness and so forth. What if she'd recently had bad asthma and she was put on prednisone? What changes might you see in her white blood cell counts because of the prednisone? And here, the question, what would you see in her white blood cell counts? You guys are on fire here. When we get to 60, we'll stop. Unless some of you are getting lazy and not going to vote on all of these. Oh, okay. Okay. So we'll close here. Huh. Okay. So everyone agrees that prednisone, that steroids make neutrophils go up. And that's correct. Oh, I'm sorry. I'm reading this incorrectly. Everyone is... So everyone agrees that the lymphocytes go down. And that's what I taught you yesterday. Interestingly, almost all lymphomas, which are cancers of lymphocytes and lymphocytic leukemias, any cancer of lymphocytes, there are regimens for them that include steroids in them, because you can kill lymphocytes easily with steroids, and they're not chemotherapy, but they use them with chemotherapy. So this is how they're immunosuppressant steroids. Importantly, you just have to remember this, there are certain neutrophils which hang out in the bone marrow, there are certain neutrophils which hang out in circulation, and there are other neutrophils which hang out on the side of blood vessels just waiting for something to happen, for there to be some kind of chemical stimulus telling them there's an infection, and they'll go to it. And so what steroids will do is they'll take this demarginated pool of neutrophils and they'll make them go into circulation. So within a day of getting exposed to steroids, you'll see the neutrophil count go up. The lymphocyte count will get depleted, will start to go down within a week or so. And so you'll see an increase in neutrophils and a decrease in lymphocytes. People see the increase of neutrophils and they say, oh, well, the immune system must be getting stronger since the neutrophils are going up. But neutrophils are fairly stupid by themselves, and you need the lymphocytes to coordinate the immune response in a bad infection. So, ultimately prednisone does not help your immune system, even if it does make the neutrophil count go up right away. Yes?
So ultimately, though, with time, both will be down if you're on long term?
So long term, some people will continue to have an elevation in the neutrophil count, but some people return to normal. But the longer that you are on steroids, the more your lymphocytes will get depleted long term. So this woman has iron deficiency anemia. The labs are classic. Iron is low and TIBC is high, so saturation is low. Her ferritin is low. And again, she's premenopausal, so the assumption is that she has iron deficiency from that. And she started on oral iron, and she gets better. And then her symptoms come back again. And she's lost 10 pounds over the past 2 months. And then the doctor takes a more careful history, and looks like she may have actually hit menopause about 4 months ago. And so she's presenting again with symptoms of anemia, but she hasn't had a menstrual cycle in 4 months. So you can write down these labs. And she's gone from having normal blood counts to being anemic in 2 months. This is not an easy question here, but the point is not for you to get it right, but to think about it. If you want to discuss it amongst yourselves, I won't rush you on this one. We'll close up in 20 seconds. Okay. Last year I got rated poorly for picking on vegetarians, so I'm going to be very genteel. So, vegetarianism, even though, you know, as Dr. Hart pointed out yesterday, the iron that's in fruits and vegetables is not as immediately available as a steak, but you can still absorb it from your diet. So, a strict vegetarian, I mean, unless they avoid raisins and spinach and broccoli and Brussels sprouts and safflower oil, you know, they'll still get it. They should, a diet by itself should not make you iron deficient. You know, again, it's not as bioavailable, but you'll get it. You'll learn tomorrow, strict vegans, unless they take vitamins, can become vitamin B12 deficient, because the only natural source of vitamin B12 is animal matter. But you can get sufficient iron from fruits and vegetables that you will not be iron deficient if you don't have excessive blood loss. So, could this be, how could, you know, who said tuberculosis? Why might this be tuberculosis? So, I mean, she has systemic symptoms, which makes you think about tuberculosis. That's, you know, that goes in its favor, but she doesn't have pulmonary symptoms again, which goes against it. But you're right about that. Were you raising your hand there, or just stretching? Exactly. And so, it's, again, I'm not giving you this question. Your best teachers, you'll realize at one point as doctors, are your mistakes. So your point is not for you to get this right the first time, but to think through this. And so if this patient, her anemia corrected 2 months ago. So if she had sufficient iron in her body, then now if she had tuberculosis again, you'd expect her ferritin to be elevated. And her ferritin is 23, which is kind of barely out of the low range. And so That's a bit of a clue, along with the lack of pulmonary symptoms, that this is less likely to be a recurrence of pulmonary tuberculosis. Now, she could have tuberculosis somewhere else in her body now and not have pulmonary symptoms, but again, with the iron repletion from 2 months ago, you'd expect ferritin to be high. So, all of you got that A, none of you said A, and that's good, because she hasn't had a period for 4 months, so that shouldn't be the case. And you can say bleeding from known site, and that's possible. You know, this is a point that you'll appreciate more, but I was thinking of colon cancer, and what you'll kind of be taught, what you've been taught already in GI is, iron deficiency anemia in a man is often considered to be colon cancer until proven otherwise. That's also should be, to some extent, assumed in women when they hit the age of 50 and they hit menopause. And so you need to take a careful history from women in their 40s, because there are women in their 40s who will still have their periods and can develop colon cancer. And they're rare, but they're out there. And so you need to take a menstrual history and see how great their blood loss is, and also just ask them whether or not they see blood in their stool and see, blood in their stool, whether or not they have a change in bowel habits, whether it's pain or a change in stool caliber and so forth. And so she's 50 years old, and she's reached the age where she wins a screening colonoscopy. So you would want to think about colon cancer in this patient. Case number 2. This is a woman with rheumatoid arthritis. I don't think you've had rheumatology yet. But this is an inflammatory form of arthritis that affects the fingers, the shoulders, the hips. It does lots of bad things. It's very painful. And it's an autoimmune disease, an inflammatory disorder. And so it's often treated with prednisone, but sometimes you're given methotrexate, which is a folate antagonist. It's a mild form of chemotherapy, so to speak, that can be used to treat an autoimmune disease. And often people with rheumatoid arthritis are treated initially with prednisone, but if a low dose of prednisone will not do the trick, sometimes it'll be put on a once weekly pill or oral methotrexate therapy. And so she was getting treated, and she ended up with diarrhea and had little oral intake for a few days. Whenever a lecturer or an exam question mentions diarrhea or vomiting and poor oral intake for a few days, they want you to think about dehydration and what that can do to the kidneys, which you haven't really learned about yet. And she has pneumonia. This is what her blood smear looks like. This is low power. What's notable for this smear? So it's hard to tell for you guys on low power, but you can see that these purple spots here, this is not Barney. These are white blood cells, the nucleus. To my eyes, these are kind of circular or blobby or kidney shaped, and here you can see one cell that's got a segmented neutrophil. And so with experience, you can appreciate this is a patient who has neutropenia. And so even before you can look at this patient's blood under the microscope and see that she's neutropenic, that she has low neutrophils, say before she even gets her blood count back. Creatinine you'll learn about when you study urine in the kidneys. And again, the higher the creatinine, the less functional your kidneys are. So this patient's in renal failure. And here you see her blood count. She's neutropenic, leukopenic, anemic, thrombocytopenic, and ferritin is very elevated. If you guys want to discuss this amongst yourselves again, go ahead. Rachel Gordon, actually. Yes. Okay. 30 seconds. Ten seconds. 4, 3, 2, 1. Oh, still getting votes. Okay. Cool. So kidney failure does not do anything to neutrophils. So again, it's kind of hard for you to appreciate that because you haven't learned about the kidneys yet. But I didn't, I did bring a smear, I did put up a smear about neutropenia yesterday, and kidney failure is not on it. Again, neutropenia, ethnic neutropenia, I discussed yesterday, it's very common in African Americans and in dark-skinned Hispanics. The important thing is that it's something it's something fairly constant over time. And so if this patient, if she didn't have neutropenia before, then you wouldn't be able to invoke her ethnicity as a cause of it now. And so this woman's had regular blood tests, and if no one's told that she was neutropenic before, then you can't really blame her ethnicity on it now. You can think about acute leukemia. But they would have reported leukemia cells on the blood smear. But, leukemia is always there to surprise us. Felty syndrome you'll learn about. It's extremely rare. I think I've seen one case of it in the past 5 years. And it's something that happens in rheumatoid arthritis where patients develop very large spleens and they have neutropenia with it. And it's very rare. The answer here, which is, the more common thing that could be, this could be Felty syndrome. But based on the history, you can feel a bit more confident saying that this is methotrexate toxicity. What you haven't been taught yet, again, methotrexate, it's a folate antagonist. It's a form of chemotherapy, and it targets rapidly dividing cells, in this case, cells that cause rheumatoid arthritis. And here you have methotrexate toxicity because methotrexate is cleared from the body by the kidneys. And so when you have kidney failure, methotrexate levels will go up and you'll get cytopenias. And the fact that this patient had pancytopenia, all the cell lines were reduced, is kind of a clue of methotrexate toxicity. And one of the things that pushes you away of invoking ethnic neutropenia. So, in this patient, what is not a cause of anemia? And since you guys are talking so well with each other, we can do that again. Thirty seconds. Okay. 10 seconds. Okay. Okay, good. So the majority of you got this right. The ferritin is 1,000. It's extremely elevated, so that will exclude iron deficiency for you. And so a lot of this other stuff that you're being asked about here, you know, was stuff that you're just learning for the first time. Remember, the kidneys, as I showed you yesterday, tell the bone marrow to make red blood cells. They produce erythropoietin, which tells the bone marrow to make red blood cells. So if your kidneys are not happy, they stop making erythropoietin, and you become anemic. Dialysis patients are basically perennially anemic unless they get treated because their kidneys can no longer produce erythropoietin. Rheumatoid arthritis is an inflammatory disease, and so it can produce anemia of chronic disease, anemia of chronic inflammation. And there's some patients, pneumonia will do the same thing. Methotrexate, again, you've just heard about this for the first time from me perhaps, but it's an anti-metabolite. It's a folate antagonist. It targets rapidly dividing cells. And so this will affect red blood cell production the same way it affects production of white blood cells and platelets. So I think that is it. Should we look at some blood smears for 10 minutes, or are you guys fried? All right, we're going to do it. Yes?
When you have the iron lab up there,
Yeah.
you don't have to go back and wait for this earlier. What is that actual measurement?
You mean the test called iron?
Yeah.
The test called iron is basically how much iron is circulating in blood. It's just the iron ion in blood. That's it. And so, again, I could be completely iron deficient and take 5 iron pills, and my level will suddenly shoot up. But everywhere in my body, I'm deficient. My liver doesn't have enough. My bone marrow doesn't have enough. So it's a very deceptive test. Meanwhile, I ostensibly do not have iron deficiency, but if I fast for 24 hours, you take my blood test right before I eat, my serum iron level will be low because I just haven't had a meal in a while. The serum iron is a useful blood test. When you see a high TIBC and a low serum iron, that really helps confirm for you that there's iron deficiency.
Does free iron, does it cause like oxidative stress? Or is
Yes, it can. There's something called non-transferrin bound iron, which was mentioned briefly yesterday, and free iron is free to react and cause trouble.
So it is the non-transferrin bound iron?
The iron that's measured in serum, I believe, is transferrin bound. Yeah. There is a way of measuring non-transferrin bound iron. It's not something that we traditionally do. All right, so this is just going to be me going over the bread and butter with you. And you guys got these yesterday. This is a normal smear. All of the, you see a monotonous red blood cell population. There's not a big difference in terms of their shape and size. They're all circular. They're all about the same size. They don't have excessive central pallor. And here you just see 4 neutrophils. This is normal. They have anywhere from 2 to 4 nuclear lobes. And you see these little pieces of dirt, and those are platelets on a clean slide. This is high power. Again, the central pallor should be no more than 1/3 of the cell's diameter, which is what you see. Here you can see the platelets better. There's no nucleus here. And there's no nuclei anywhere here. These are just the platelet granules that appear purple. These polychromatophilic red blood cells that have a slightly purple color and that are larger than erythrocytes, these are reticulocytes. These are slightly immature red blood cells. And when you see an increase of these, you have reticulocytosis, and it means that the bone marrow is trying to compensate for anemia. So if you have hemolysis, you will see 1, 2, 3 of these at once. If you just gave a pint of blood, the same thing will happen. The slightly purple hue here is a little bit of residual RNA inside the blood cell. And this gets degraded, before it becomes a fully mature erythrocyte. RNA doesn't last that long. This is something called rouleau. This looks like a stack of coins here. And I believe that rouleau is French for a roll, or something like that. French is not a language I speak, but in any case, normally red blood cells repel each other. They have slightly negative charge. And so you will see rouleau in inflammatory conditions because in inflammatory conditions there's an increase in antibody production sometimes. And antibodies are positively charged. And so you end up having antibodies not bound to red blood cells, but they're basically on the smear here, and they kind of help negate the mutually repulsive negative charge here, and that allows the red blood cells to stack up on top of each other. So when you're taking care of patients next year, if you get a report from the laboratory that says rouleau, that's a clue. Again, they're seeing red blood cells stack up on top of each other in the smear. That's a clue that there's elevated antibodies and there's something inflammatory going on. It may not be an infection, but you can see this in HIV, you can see this in hepatitis C, you can see this in certain blood cancers. These are the red blood cell precursors in the bone marrow. This is from the textbook, which I didn't recommend to you. And you can these are just the different stages of erythroid maturation, the bone marrow, and you won't, this is just kind of for your listening pleasure, not so much for you to be tested on. You can see with time they become smaller. They have very dark pycnotic nuclei. The cytoplasm goes from a dark purple to, to a light pink over time. And this is how you can compare a mature erythrocyte to a reticulocyte to the bone marrow precursors, the normoblast. This is, whether or not they have DNA, whether or not they have RNA, where they're found. And this is a useful way of just comparing them. White blood cells. Again, a lot of this, by the way, this is just repetition. This is all 5 of the cells that you'll be responsible for learning on one slide, so you can compare them to each other. The neutrophil has a segment in the nucleus. The basophil and the eosinophil both have bilobe nuclei, but one of them has granules overlying the nucleus and the other one doesn't. This has big red granules and the other one has big purple granules. This has a reddish cytoplasm, whereas the lymphocyte has more of a purple cytoplasm. The lymphocyte is the smallest of all of the white blood cell precursors here. The monocyte is ugly and kind of has a kind of deformed kidney-shaped nucleus here. This is just another way of looking at hematopoiesis. This, I showed you 2 different slides of this yesterday on the stages of maturation. I don't think you'll be tested on, the sequences, but remember, pro in Greek means before and meta means after. And so it's easy to remember pro-myelocyte and metamyelocyte. Before this is the blast, and then you have the band and the neutrophil. It is not unusual, certainly neutrophils you'll see all the time, bands you'll see in infection. If you see something before a band in circulation, then something weird is going on. Yes?
How can you tell a band from a monocyte?
So, the monocyte has more of a lacy cytoplasm, whereas a band has a much more clumped, darker purple, not cytoplasm, nucleus, has a lacy kind of chromatin in the nucleus, and the band has a dark purple clumped nucleus. A band will have more granules than a monocyte, and a monocyte is kind of more likely to see vacuoles like you see here. I'm generalizing things. But in general, it's the monocyte nucleus is more kidney-shaped. It has a lacier nuclear granularity compared to the band. I don't think Dr. Garrett's going to give you something which should be confusing between the two. Neutrophil, red cytoplasm. Just look at how clumped that DNA is. This neutrophil is going to live for 6 or 12 hours, so it doesn't need its DNA for very long, and that's why it's so clumped. And you can see a lot of granules in there. The same thing, and by the way, you may say to me, well, this is red and this is purple, but they're supposed to be red, and sometimes the machine just overstains this. In general, the neutrophils should have a reddish cytoplasm. And these are band forms. And like you were asking, just look at how dark purple this is. And we'll compare this to the monocyte in a second. There's several of these, and they have lots of granules here and no vacuoles. Let's just skip over this. Sometimes you can see something called a Durley body, which is this blue form right here. This is rough endoplasmic reticulum, and this is something you only see in a severe infection. to overgeneralize again. These are different kinds of lymphocytes. This is the kind of most common garden variety lymphocyte that you'll see. Don't worry about this one. This is what you see in like mononucleosis. This is an activated lymphocyte. This is a less common lymphocytic form called a large granular lymphocyte. And this is a plasma cell, which you'll learn about in the cancer unit in the fall. But this is what you'll mainly be tested on now. It's small, it's got a circular nucleus, very pycnotic DNA. Purple cytoplasm, circle, nucleus, circular shape. They can have an atypical appearance. Something like this sometimes might confuse people, and they might wonder whether or not it's a monocyte because it has a little bit of a kidney shape to it. And sometimes it can be confusing. The lack of vacuoles here and the way the nucleus looks to me, it doesn't have a lacy appearance, is a clue to me as an experienced hematologist that this is an atypical lymphocyte and not a monocyte. Just know that these things exist, LGLs. So this is a classic monocyte. Again, the chromatin has more of a lacy appearance as opposed to a clumped appearance. You see lots of vacuoles here. Kind of kidney-shaped nucleus. Here's another one. This is a monocyte that this could be confused for a band. In my mind, it's a monocyte because of the vacuoles, that you don't see a lot of granules. The cytoplasm is purple rather than red, but this could be confusing to someone who hasn't done this a lot. Eosinophils, they just have a very classic appearance. Bilobe, big red granules. These guys are rare. We're excited when we find one. And if we find more than one on a smear, then we get worried about some kind of blood cancer very often. And again, we don't really know why we have them. Bilobed, big purple granules that go over the nucleus. Okay, thank you. Hi.
Was everything going okay?
Yeah, everything went fine. Which just goes to show you that people should not use Macintoshes.
Okay, great.
I've used Turning Point before, so I felt fairly comfortable with it.
Yeah. Great.
Thank you. Hi.
So, how do you define iron deficiency? You don't use blood serum levels to define it.
Not by itself. You have to use iron and a high TIBC and a low ferritin in conjunction.
So, if you have high ferritin levels but low blood serum levels, that iron is sequestered in cells. That's not bioavailable.
It's not bioavailable, but you're not iron deficient. It's called functional iron deficiency.
You have clinical symptoms of iron deficiency.
Not necessarily. You could have clinical symptoms of anemia, but not of iron deficiency. So you won't be eating ice cubes, but you'll still have anemia symptoms. So you'll be anemic, but not feeling like you're iron deficient. most of his feelings about it. I think as you appreciate the tons of stuff that he taught and you can't see, you know, and I can't, you know, there's only very limited amounts of you guys can expect to know about the I should know that there's white blood cells and all this but you won't be expected to know everything when it comes to communication. You might be expected to understand, you know, whether or not somebody has PCP, whether it's not cystic fibrosis,
Oh yeah, they left everything off. I'm like, I just wanted to make sure they turned everything off before. This is where this goes. Okay. Were you guys having a test or something?
No, it's one of those exam reviews, but I don't know if anybody set it up properly.
No, you know, this doesn't go here.
Is that the doctor's?
This is for the clipper.
Oh.
So you don't usually leave it in the side. Leave it in the back. Yeah, because people will see that and go, oh, look.
That's my USB port. Had a few of those reported.
Well, since somebody left this up here, let's just see if this works. Good, it works. Good. Just leave this here. Do you want me to turn this stuff on, or?
I don't think so.
Okay, they're not going to need anything?
I think they just come in and do their exam. The faculty come and...
Want me to turn the lights up a little bit?
Yeah, the lighting is weird in here.
Well, this is the slide line.
Oh, is it?
Yeah.
Wow. Much better.
This is all on.
Much better. Thank you.
The
Hey,
top
Aaron.
one.
Top one is all?
It's all.
Thank you.
What's that? I mean, no, Nicole cleared my schedule till 1:30. There's apparently, they have access to their exam online somehow. And Beverly's trying to like. Okay. Did you send it back to me? Or? Jesus Christ.